So we are here to talk to you about the clinical based scenario. Hi, Lokesh. Good to have you in the session. Can you just unmute yourself for a minute? Okay. Whenever it's feasible, you can definitely unmute and you can interact because I would like to have a two-way conversation. If at any point, if you want to ask anything or if you just want to interrupt, you can definitely do that. Not an issue at all. Okay. So yeah, let me just start. So here what we have is we have a 35-year-old man presenting with the left leg swelling and the pain for few days. Okay, so there is a left leg swelling and the pain for few days, which has been there. And the symptoms started 3 days ago after a long car trip to from Florida. So the patient basically took a long car trip, and after that, the pain basically started. Okay, now the pain is described as an ache and no prior episode. So this is the first time the patient is basically developing this particular pain, which basically tells you that it is not a kind of a pain which is like a Burgess disease. Okay, so it's not happening with walking. It's basically the patient was sitting in the car, and it is the first time pain. So it has never occurred in the past. Now, patient is otherwise healthy except smoking half a pack a day. So, patient is a smoker, which is one of the risk factors for the peripheral vascular disease. But the above history has just told us that you know what, you're not dealing with the patients with the peripheral vascular disease. What you're dealing with something, we'll talk about it. Okay, right. Now, no medication or the family history of clotting disorder. So, the patient is not taking any particular medication, or there's no family history of some protein C or protein kinase deficiency or something like that. Now, on physical examination, there is an asymmetric left leg swelling. So the swelling is basically present only on the left leg, which is sparing the foot. So foot is not involved. What is involved is just the leg. So mainly the calf and all those things are involved, but the foot of the patient is not involved. Now, the neurovascular examination is normal, but the pulses are Dopplerable only due to the swelling. Okay. So yeah, overall the examination is perfect, but when you try to kind of palpate the pulses, you're not able to do that. But with the Doppler, yes, you are able to kind of hear that the pulsations are present. And the reason why probably you're not able to palpate the pulses is because of the leg swelling. So this is what is a clinical scenario of a deep venous thrombosis, because here you have a patient who had a immobilization because the patient was traveling in a car, probably the patient did not move the legs and all those things. And because of that, the patient has developed, sorry, a deep venous thrombosis. Okay, so the differential diagnosis is the most likely the patient is having a deep venous thrombosis. Now, in the patients with a deep venous thrombosis, what is your fear? Like, what is the risk these particular patients have? So, these particular patients have a risk of pulmonary embolism. So, obviously, we do know that there is a deep venous thrombus, and this thrombus can get detached and it can go to the lungs, which can lead to a pulmonary embolism. Are you understanding my point? So yeah, this is what is a deep venous thrombosis, and the thrombus can detach and it can basically go to the lung, leading to a pulmonary embolism. Right. Now, another thing, or what you would call as a severe form of a deep venous thrombosis is something which is called as a phlegmasia cerulea dolens. Now, what is this phlegmasia cerulea dolens? So, phlegmasia cerulea dolens is basically whenever you have a massive deep venous thrombosis, which has caused the leg swelling, it can also lead to some kind of an ischemia. Okay, so here there is a patient who is having what you call the image of the patient, where you are having the massive swelling of the left leg because of the DVT, which has led to the kind of ischemia of that particular left leg. So this is what is a characteristic description or the image of a phlegmasia cerulea dolens, which is basically the painful blue leg. Okay, so what is phlegmasia cerulea dolens? It is basically the painful blue leg. That is what the patient is having. Okay. Now, other causes of the leg swelling can be hematoma, so some amount of the bleeding. Yes, that can be there, hematoma. Unlikely due to the absence of any trauma or anticoagulation in these particular patients. It's unlikely to have that because there's no history of, in particular, of a trauma or any chronic use of an anticoagulation which has been given. Lymphedema usually involves the dorsum of the foot and it may be kind of iatrogenic. So, but again, there's no history of any lymph node dissection or an inguinal node dissection or something like that. So this is not a lymphedema. It is basically a DVT. And there can be systemic causes like the congestive heart failure or the nephrotic syndrome, but here usually the swelling will be bilateral, but here you had a swelling only in the one leg. Okay, so these are the differential diagnoses which you would have if at all the patient is coming to you with a swelling of one leg. Okay, so the first thing according to the history would be the DVT, but then the others can be hematoma can be there, lymphedema can be there, and systemic causes like the congestive heart failure or nephrotic syndrome. All those things can be there. Okay, now let's talk a bit about the venous thromboembolism. Okay, so venous thromboembolism, it is basically quite common. It is basically occurring in more than 9 lakh cases every year. Okay, that's the Western data, that's fine. But what you need to understand, it's not a rare kind of condition. It's a common condition. It happens. It's you will find it, a DVT at one point or the other. Okay. Now, whenever you suspect and any particular patient is having a deep venous thrombosis, what will you do? You will perform something which is called as a Doppler ultrasound. Okay. So Doppler ultrasound has a sensitivity and the specificity of more than 95%. Okay. So Doppler ultrasound has a sensitivity and the specificity of more than 95%. Now, the grayscale imaging for an external iliac femoral and the popliteal vein. So what you basically use in that is a grayscale imaging. Okay, so the grayscale imaging is basically used for the external iliac femoral and the popliteal veins. Okay, so that is what you need to understand. Now, in the Doppler ultrasound, what you basically do is something which is called as a compression testing. Now, what is this compression testing? So if you have a normal vein, it is going to collapse completely. Okay, so when you compress with that particular probe, the normal vein is going to collapse completely. But if at all there is a patient who is having a deep VT, deep venous thrombosis, or the thrombosis basically present inside the vein, when you compress, there is going to be the partial compression of that vein. The entire compression is not going to be there. Are you understanding my point? So this is the image. As you can see over here, this is the vein. So when you compress, it gets compressed completely. So this is what is a normal vein. On an ultrasound, when you compress with the probe, the vein basically collapses completely. So that is normal vein. But over here, as you can see, this is again a vein. But when you compress with the probe, the entire vein is not collapsing. So here inside this particular vein, what you have is a thrombus. Okay, so what you have is a thrombus. Okay, yeah. So what I was talking about was a compression testing. So what I was wanting to tell you is that in the normal individuals, when you do the compression testing, the vein is going to get collapsed completely. But if at all there is a patient with a DVT or something, on giving a compression, the vein is not going to collapse completely. There's going to be the partial collapse of the vein. So yeah, that is what is the difference in the compression testing. Okay, understood? Right. Now, acute versus the chronic clot kind of feature. So when you look on the ultrasound, there's a difference between an acute clot versus a chronic clot. So what is the basic difference? Okay, so the acute clots is ecolucent and the vein is kind of enlarged. So there's a vein enlargement and the acute clot is ecolucent. But in the chronic clots, what you have is the eco-density. So it is eco-dense. It is like more ecogenic and the vein has become shrunken and there is a heterogeneous appearance. So you have a eco-dense, they are kind of more ecogenic. The vein has got shrunken and it is having an heterogeneous appearance. So these are the features of what you call as a chronic clot. In the acute clot, what you have is it is an eco-lucent with a vein enlargement. So that is what you have in the acute versus the chronic clot. So in the acute, loss of compressibility, ecolucency is there, lack of collateral vessels, venous distension, and the surrounding inflammations. That's what is the acute. In the chronic, you have a loss of compressibility, increased ecogenicity, presence of collateral vessels, shrunken fibrous cord, and no inflammation. So these are the features of your chronic clot. Okay. Now, on the color Doppler, you assess the partial versus the complete kind of occlusion, as I just kind of shown you with the compression test. With the color Doppler is going to kind of give you the confirmation of that. So lack of respiratory variation, that is proximal obstruction. If at all there is a lack of respiratory variation, it's basically like a proximal kind of an obstruction. And flow augmentation, it kind of evaluates the distal patency. So these are the few things which you basically are the features of your color Doppler. It's fine. But all you need to understand as a surgeon, at least you should know about the compression testing. On the compression, if at all the vein is getting collapsed completely, it is a normal vein. But if at all the vein is not getting collapsed completely, if at all there is a partial collapse of the vein, then what you have is a deep venous thrombosis, which is basically present inside those particular veins. Okay. Now, so now coming to the management. So how do you manage these particular patients? So what you have to give them is an anticoagulation. Okay. So what are the anticoagulation therapies which you kind of use for these? So you have an unfractionated heparin. We don't use it anymore, but yeah, you can use it. but it has a lot of problems. Like it can lead to heparin-induced thrombocytopenia and all those things. So usually we don't prefer it. What is usually used nowadays is this low molecular weight heparin, LMWH. Okay, so you use that definitely. And what you